Thank you very much, the organizing committee of WCES and IAGES for giving me this opportunity to moderate this panel discussion on this very important topic, bile duct injuries in laparoscopic cholecystectomy. This is going to be a discussion for about 30 to 40 minutes. So we're going to have Dr. Manish Baijal, Dr. Senthilnathan, Dr. Arupabha Datta, and Dr. So could all of you please, can we have another chair, please? We need one more chair. Okay, right. So, right, just to set the scene, we know bile duct injury is a serious complication, and if you look at the literature, it's only 0.3 to 0.7%. And if you think about it in broader terms, 0.3 to 0.7% is nothing in any surgical procedure. But then you have to understand that the hundreds of lap choles done by every surgeon and the thousands that happening worldwide. So that we're looking at 0.3 to 0.7% of a huge number of patients, and therefore that's a significant number which cannot be ignored. And the worrying part is that 70 to 85% of these bile duct injuries don't get recognized at the time of lap chole. Now, let me start off my discussion with my panelists, my esteemed panelists. If I may start from the right, Bharat, what do you think are the risk factors for bile duct injury?
I would blame the surgeon himself.
Okay.
And definitely there are other risk factors like difficult anatomy and the patient's profile and complexity of the clinical condition. So, but even before all these other risk factors, I would again.
So you would put surgeon factor as the number one factor.
Yes, right. I would put that.
So can I come to you, Arupabha? Dr. Bharat says surgeon factors. What sort of factors? I mean, why would one surgeon be more prone to giving a bile duct injury while the other one is relatively safer?
I would little correct that. I mean, when I meant surgeon factors, it includes the instrumentations which he has
surgeon and the facility in which he operates. Fair enough. Would you like to add on to that?
Yeah, that of course is a factor, depending upon the experience. At the outset, let us say that bile duct injuries can happen in every case.
Okay.
Within the simple case. So the importance of the surgeon is concentrating on the basic facets of doing a safe lap chole, the importance of obtaining CVS in all cases. So those are the surgeons, I would say. And also you need a very good imaging and all those sorts of things. But of course, in the patient factors, maybe the anatomy, in acute cholecystitis and empyema, I would put one as a very dangerous scenario is a scleroatropic gallbladder. That is a very difficult scenario.
Sorry, what was that?
A scleroatropic gallbladder. Very
a shrunk and shriveled gallbladder. Chronic cholecystitis type of gallbladder.
That can be one of the most difficult scenarios.
Okay, all right. Okay, fair enough. So just to summarize, there are, there are 5 different factors: anatomical, patient-related, and then the pathology itself, and then the learning curve, and last, of course, the surgeon factors. When it comes to surgeon factors, Dr. Manish Baijal, what do you think of the statements made there? What are your comments? Which of the 5 do you think contributes number 1 to bile duct injuries?
I would add actually another point out there is inadequate training.
Inadequate
training.
Yeah. Well, we listed that as learning curve, surgical technique.
No, you're talking about surgeon factors.
And in the surgeon factors, yes, in addition to the training part of it, the surgeon who's adequately trained, who still gets into a problem due to one of these. The first one is quoted in the literature, and the first one, to be honest, in the literature it says the well-trained surgeon gets his first bile duct injury when he is just about crossed 200, 250, because that's when he becomes overconfident. And so he's gone past the learning curve, which is why I have not put the learning curve part in this particular slide. But yet the bile duct injury can happen.
Yeah.
What about the last one?
Actually, a lot of surgeons are doing surgeries with no second opinion available to them.
Yeah.
So if you're working as a team, you're working in a bigger place, you can get opinion.
Absolutely.
But you get a lot of these surgeries in places where there's no opinion available.
Absolutely. That's the point I want to get across. Many of these bile duct injuries could be prevented. All it requires is a telephone call. A telephone call to a colleague of yours who's probably in the corridor, who's probably operating next door, or a telephone call to a friend of yours who's outside, who might want to pitch in, or who might even want to have a look at the photograph of your laparoscopic screen and then talk to you. An extra 10 minutes, 15 minutes, half an hour doing this is going to save another 15, 20 years of trouble for your patient. So bear that in mind. Okay, simple cases. This is a 40-year-old woman who apparently had an uneventful laparoscopic cholecystectomy. She's still in the hospital. She's not discharged, not a daycare patient, overnight stay. 350 ml of bile in the drain first day. Overnight, she's had pain. She's required tramadol injection, and the surgeon who does this operation doesn't usually advise tramadol, so this is slightly out of protocol. The next day morning, the registrar feels the tummy. There's a bit of tenderness, but no peritonitis. That's the point I want you to note when we plan about the management part of it. No peritonitis, normal vital signs. And it's not a routine thing to do blood tests after lap chole, but since this patient was unwell, the doctor on duty the previous night had done an LFT at 5 a.m. and at 10 o'clock, you see the patient in your ward round. Senthil, what would you do?
It's a normal lap cholecystectomy, about 350 ml of drain, bile in the drain.
Correct.
I think we need to investigate with the bloods first.
LFT normal.
LFT, no, then the counts.
Count is normal too.
Normal, right. Then we have to go for imaging.
So vitals normal, LFT normal, counts normal. Only, sort of red alarm features are tramadol injection overnight, patient not mobilizing, and a bit of tenderness in the upper abdomen. Of course, you've got bile, frank bile.
Yeah. So mostly, next investigation would be an ultrasound. Ultrasound, not will pick up small collections, but nevertheless, as a first readily available investigations, ultrasound, if not CT, then if there is no drain, no collection.
But Dr. Senthil, this patient has a drain and she's got 350. I'm just asking this for the purpose of discussion. This patient has a drain and there is 350 ml of frank bile coming down the drain. What value would an ultrasound add in this particular scenario?
Any undrained collection, maybe a small undrained collection. That may be one thing. And looking at the history, it can be a lateral injury, either a cystic duct stump leak or a lateral injury, either a diathermy injury, which would have got, or a flipping of the accessory, any of the accessory duct. So that can be a possibility.
Okay.
And 350 ml is too large to be ignored. About 30-40 ml, it's okay. 350 ml, half of the bile is coming out through the drains. So
Yes.
we need to investigate and then actively intervene as far as that scenario is concerned.
Okay. By the way, Dr. Bharat, is there any role for waiting and watching? Because we are looking at 18 hours post-surgery. You did the operation at 12 noon, and this is the sort of 8 a.m. ward round.
I would
the
be
following day.
surprised. The reason why is you mentioned it's an uneventful surgery, and yet there's a drain.
Well, uneventful according to the surgeon.
Yet there's a drain.
I mean, we just said that in the introduction.
So,
70 to 85% of bile duct injuries don't get recognized.
That with a caution.
Yeah.
And if there is a video available, I would definitely review the video. And since the patient is doing fairly well, except for the large amount of bile which is leaking from the drain,
right?
Initial wait and watch wouldn't be a bad idea to do.
Fair enough. Okay, so Dr. Arupabha, we let's say this patient was decided to be subjected for an ERCP. although it's only 24 hours, due to the fact that, there was frank bile and the surgeon was pretty certain that there was something not quite right, and he wanted to do an ERCP, which is fine. ERCP has shown a cystic duct leak. What would you do? A cystic duct leak, basically, it's not a major BDI.
Yeah, so since you have already gone in for an ERCP, it makes to put in a stent. And the one thing you should not do is again go in and try to close that cystic duct leak. So once
So there is no role for re-laparoscopy here.
No, not in this. Once you've done an ERCP, put it at the drain. The idea, if need be, you have to assess whether there are other collections, because bile in the abdomen is a very notorious thing. So you have to assess that there are other areas which have collection. That has to be drained with maybe pigtail catheters. Put in a drain, most of them will settle down once you put in a stent.
Yeah.
Jameel, just to add, if it's a cystic duct in a normal gallbladder, cystic duct stump leak, see, you clip it. It's a healthy cystic duct. I'm not talking about the inflamed, friable ones. In normal ones, the leaks can be basically because two reasons. One, there is a obstruction down below in the bile duct.
Yes.
Blow out of the cystic duct stump. That's one reason. Or the second reason is crushing of the clip onto the cystic duct. Sometimes vigorously you just, with the shaking hands, with the double hand, you just apply. No need to apply those kind of
absolutely.
Crush.
So you
need to crush the cystic duct.
You need to think out of the box here. You need to think. Yes, you know that there is a cystic duct leak, but as Dr. Senthil quite rightly said, you need to think, why would that small cystic duct leak out 300 ml of bile? Is there a distal obstruction somewhere, or is there more to it? So anyway, so that's the flow chart. Basically, if there is a drain, you leave it, and then you decide whether the patient has got peritonitis or not. If the patient has got peritonitis, sepsis, yes, you go ahead with an ERCP stent, and you might even want to re-laparoscope, as Dr. Senthil earlier mentioned, to look for any undrained collections and put a drain. But if there is no peritonitis, there is a role for waiting and watching. Somebody mentioned waiting and watching. There is a role, but then you have to, it's a clinical call, and you need to assess your patient every day, and you need to see the drain output every day, and then take an appropriate decision. So classifications of bile duct injury, I'll just quickly go through the theoretical part of it. We all know this: Bismuth, Strasberg, McMahon, Stewart. Strasberg by far has been the more popular classification in the laparoscopic era, and Bismuth was in the open era. A, B, C, D, quite familiar to all of you. E being the major bile duct injury, categorized again into 1, 2, 3, 4, 5 based on the Bismuth. This seems to be very popular these days. Atom classification, to such an extent that in the recent guidelines, the World Society of Endoscopic Surgery, World Society of Emergency Surgery guidelines on bile duct injury, it is emphasized that the surgeon who has inflicted the bile duct injury, when he is on the telephone to somebody or when he is writing a note to somebody, is better off describing the injury as per the atom. And what is atom? Atom is not just about the level of the injury. It is not just about the bile leak. It is about the anatomy of the injury, the timing of the injury, the mechanism of the injury, and also the presence or absence of any vascular injury. So it's quite important. It's a big table. I don't want to go into the details of it. You can all read it up. Okay, back to our panel. Dr. Manish Baijal, as a surgeon, what are the measures that I should adopt to prevent a bile duct injury?
So I think one single most important thing is to use your diathermy very judiciously, because that is something which is very common and responsible for these partial injuries, delayed injuries, in which you have a ischemic injury to the bile duct and you have a leak that happens on the second or a third or a fourth day. So that's one. And then, of course, it's all about your training, how you train yourself. Then you talk about the ruveus sulcus, stay always away from the ruveus sulcus. In case of difficulties, subtotal cholecystectomy is something which is actually needed in extremely rare situations now, because with more and more expertise and experience, you're able to dissect the calyx well, even in difficult scenarios. Of course, you have a difficult calyx, do a fundus first dissection, and Laparoscopic ultrasound is something which may not be needed in most times.
Yeah.
And in
Sorry,
today's time, with the availability of ICG, that makes things simpler and easier. So of course, I agree with most of the points out there. And you want to add anything?
Yeah, thank you. Dr. Vipulroy Rathod. Yeah, may I also kindly invite you onto the stage to join our panel discussion on bile duct injuries. Thank you. Dr. Rathod is an expert endoscopist from Mumbai. Thank you, Dr. Vipul. Yes, so yeah, well, I think Dr. Manish quite nicely enumerated the various things that one needs to take care of to prevent a bile duct injury. But I just want to, Dr. Senthil, pick your brains on those three bottom things. Well, I'll let you talk about the first one, and we'll ask our other panelists about the others. What do you think is the role of IOC in prevention of BDI? I put a question mark there. Why should there be a question mark?
It was described during the era of Kusheri, but never followed in India. When four blind men tried to figure out what is an elephant and what is a cow, those were the things when the techniques were not standardized. It was, in fact, when you see the Kusheri's first article, he suggested intraoperative cholangiogram in all the case of cholecystectomy.
I am still aware of surgeons, not in this country, in the UK, who do intraoperative cholangiogram for all lap choles, elective lap choles.
So
uncomplicated.
And how I'll tell you in this audience, how many of us have the facility to do an intraoperative
Exactly.
cholangiogram in our routine data?
Exactly. The
It's
logistics.
not practically not possible.
Absolutely.
Laparoscopic ultrasound also is very much limited. How many you can, by self, you can check how many of you have the laparoscopic ultrasound. Probably ear infrared.
We'll
ICG
come back to that, Senthil. Intraoperative cholangiogram. I mean, we all know how it's done. As Dr. Senthil quite rightly mentioned, it is not something that needs to be done for all the cases. Perhaps it was the case before the advent of high quality MRI, Alfred Kusheri's era maybe. But now with excellent MRCP, there is diminishing need for an intraoperative cholangiogram. Nevertheless, there are surgeons who still do it routinely, but we'll leave it to that. The idea of doing it is to clarify the biliary anatomy and to see any bile duct stones. But then does it really prevent bile duct injuries? That's what the SAGES says. 2017, the SAGES recommendation, it says IOC may decrease the risk of bile duct injury, but its routine use remains controversial. So we'll have to remember that. Laparoscopic ultrasound. Dr. Rathod, could I have your opinion on it? You see a lot of patients with bile duct stones. What do you think? Have you come across situations where you have felt, well, it may have been better if this was detected by the surgeon pre-operatively itself? If the patient has not had an MRCP, perhaps a laparoscopic ultrasound would have been better, anything like that?
Well, as you mentioned earlier, that I will make 2 points here.
Please.
Number one is bile duct injury. I just want to share that I was trained initially for open cholecystectomy by Professor V.N. Shrikhande in Mumbai, who was probably one of the pioneers in Western India to have pioneered a lot of gallbladder surgery. And I used to remember what Professor Shrikhande, who just passed away 10 days back, so he used to always say, there is only one bile duct. And keep it in mind all the time that something can go wrong. Only then you will be avoiding something going wrong. So that's what he used to say. Because a great man, we wanted to remember him today, since we are talking of bile duct injuries. Coming to your laparoscopic ultrasound or pre-operative investigation. For last 26 years, ever since I started endoscopic ultrasound, any patient with mild LFT abnormality, any patient with mild history of pancreatitis, MRI lipase elevation, multiple gallstones, small stones, ultrasound inconclusive, bile duct, normals, 6 millimeter, 5 millimeter, 7 millimeter, is a standard protocol, at least in my unit, that patient will undergo an endosonography before going and wheeling into the lap chole theater.
So these
So-
patients will get an EUS before
Yes,
going for a lab
yes,
chole. I see. Okay.
Because EUS
Yeah,
has
yeah.
the highest sensitivity and specificity, close to 99% in expert hands.
Correct. Yep.
Compared to even MRCP. So MRCP will miss less than 5 mm stones. And therefore, cystic duct leakage problem can be avoided if you have a protocol like this, that in the history of the patient's clinical few weeks before the surgery, if there is any history of abnormal LFT, I think it's mandatory that, and especially with 3, 4, 5 mm stones, multiple stones in the gallbladder, it is imperative that you rule out that stone before you go for cholecystectomy. It can be debated, but I think this is what has served us well to avoid post-operative leaks.
Thank,
Yeah.
Thank you so much. So I'll just quickly run through the theoretical part of it for want of time. So again, that's the SAGES recommendation. Laparoscopic ultrasound may have some advantages, but then it comes with logistics, getting it done, and not many of us many of us surgeons are trained to do laparoscopic ultrasound. Fluorescent imaging again has got some role, but its potential to decrease bile duct injury is still debatable, but it's certainly proven to be safer and more effective to intraoperative ultrasound, intraoperative cholangiography. And so yeah, so we'll go over to the next case.
If I can add just one couple of points.
Sorry.
One, of course, I fully agree that endoscopic ultrasound is a great thing, but the thing is, you have to see the availability. That's
Absolutely.
a big issue.
I said
That's a
that at
big
the
issue.
beginning.
Big issue.
Not many of us are trained to do
Yeah.
laparoscopic
Yeah.
ultrasounds, and it's observer dependent. And now we are living in an era where we have our radiology colleagues giving excellent reports on MRCP. I perfectly agree with Dr. Rathod. I mean, the EUS has got a sensitivity of 99% and MRCP has got a sensitivity of 95%. So there's that difference there. But then if you don't have somebody like Dr. Rathod in your institution, you have to depend on high quality MRCPs. And when you have those kind of radiology reports, you don't really need to do a laparoscopic ultrasound. So, yeah.
And second thing, in the steps in which you say to prevent BDI, one thing very important is something called a timeout.
Yeah,
that is something important, because a lot of these injuries happen because of perception errors. You're looking at the screen continuously for a.
What do you mean by timeout? We all do timeout at the beginning of the operation,
Yes.
but how does that prevent bile
First
duct injury?
timeout is when you assess the be safe. You see your orientation to the anatomy. Okay, you see the hepatic artery, the be safe.
I think you're talking about
two different things. Yeah, I think I perfectly understand what you're saying.
For the surgery when you announce.
No. I'm talking about intraoperative.
Yeah, fair enough.
The first thing.
So it's basically
Second,
checking with your
yes.
team about
First,
ensuring everything is all right.
When you have dissected out, you feel you have created the CVS properly. It is something which has to be demonstrated to else also. Take your time before you put in a clip. You have to be 100% sure before you put in or divide in a tissue. So that is second
Absolutely.
time out.
I agree. Right. Senthil, Dr. Senthil, you're in this situation, okay? You meaning you are the person in the last line, right? Okay, so your colleague is doing a lap chole. Your colleague in your hospital, which I know well is a tertiary level hospital, he says it was a difficult dissection. He's done the callus quite well, according to him. But as he's dissecting the gallbladder out, he sees something golden yellow coming out. He stops quite rightly, and he calls you, and you arrive.
First thing is whether I have to check whether what's going on would be in my mind is whether it is a major bile duct injury or a minor bile duct injury.
So what will you ask him to do? He's gowned up. He's with the scope, and you're there. You're just walking in. What would you want to do?
So we will again thoroughly check where exactly the golden bile is coming from.
Right.
We can easily see. We can see the site of the leak. And basically, if it is not a complete transection, it has to be a lateral injury then we can see whether
Fair
we
enough.
can
So you
suture
will
it.
you will ask him to, I mean, basically you will either scrub up and have a look, or
Yeah,
you will
yeah,
ask him to
definitely.
show
Yeah.
things better.
Obviously scrub up and
Yeah,
then
have a look.
look. Yeah.
Now your colleague tells me, sir, let me let me open up and figure out what is what. And I know you will have strong objections to it, quite rightly. Why?
No, it all depends on.
No, he just wants to open up to make sure that everything is okay, and he wants to ensure that he's not creating any permanent damage to the patient. And we all say opening up in case of difficulty is advisable, is good, and he's going by that logic. But then you have strong reservations, quite rightly. Why?
We can find majority of the bile duct leaks or bile duct injuries by laparoscopy. If we cannot figure out, then we can open. Just by seeing a golden yellow bile,
Yeah,
no need to open.
absolutely.
And again, if somebody is alone, I can tell you, somebody is alone in a center doing a standalone a surgeon with no help, probably whatever he feels, he can do it. But
Okay.
nevertheless, in my center, if somebody calls me for help, we'll go and then have a check, and then we'll try to do the suture or all those
The
things.
reason I asked that question to Dr. Senthil is that the literature clearly says you never open up to diagnose bile duct injury. I hope that message is loud and clear. You don't open up a patient to diagnose. Okay, if the bile duct injury has happened, that's fine. I mean, you refer to somebody, or you bring the HPB surgeon to your unit, you operate then and there, or you operate, 1 day later, 2 days later, open lap, that's fine. But you don't open up to define the injury and then send to somebody or call somebody, right? So never ever do
Jameel,
that.
I like to add the mindset of the surgeon working in a group practice as well as a standalone surgeon.
Yeah.
If you are in a periphery, you are the one surgeon and your team doesn't.
We're actually
know
coming to
exactly.
that in the next scenario.
Okay, right.
This was tertiary hospital. It's a
Yes.
kind of setup where you work, right? Okay, so role of IOC. Dr. Manish.
Like to add
Please.
something
Yeah, yeah.
before this. I think if a person calls you, you see a little bile there, the first thing you want to do as a surgeon who's been called in is show me the anatomy first. You look at the anatomy. If you actually see a little bile there was something wrong. If he's talking about he's already seen critical view of safety, I don't think so he's seen critical view of safety. There was difficulty there. Go away from that place. Start, get the gallbladder down, get the fundus down. I think we come to all these things much later. It is only, whatever the injury is, it's probably a partial injury. He's not clipped anything.
He hasn't.
So you start dissecting more, you wash up, get the fundus of get the entire gallbladder down, give ICG to the patient. It may be a little difficult because of extravasation of bile there.
Yes.
But still, you will be able to see the anatomy.
Absolutely.
So I think IOC comes much later. I won't even think IOC in the form of ICG.
Correct. So obviously, when you have taken over, you try and carry on from the place where he left, and if you can finish it off without requiring any of these adjuncts, that's fine. But if you're seriously concerned that there might be a BDI, you have to ask for an IOC to determine where the bile duct injury is. And let's say in this patient there was a lateral injury, a sort of a Strasbourg type D. Sharp injury, less than 1/3 circumference, and the major biliary system is intact. So just a lateral injury, just a bit of a bile leak coming from there. That's the golden yellow bile that he saw. And you as a surgeon, I mean, let's say you do say a dozen hepaticojejunostomies in a year. So you're there. He has called you. You're there. What would be the recommendation, Dr. Arupabha? These are imaginary scenarios, by the way. I mean, you don't have to specifically think about what you would do, but what is the ideal, what should ideally be done?
No, for a lateral injury, one doesn't need to go in for a bypass.
Correct. So if it's a lateral injury, hepaticojejunostomy is an overkill. And if you are a surgeon who's got adequate amount of laparoscopic suturing skills, you're perfectly acceptable to do a primary repair, external drainage. Any of those should be fine. Primary repair and external drainage with or without T-tube. The T-tube either placed through the injury or away from the injury, all of that is fine. Dr. Rathod, I want your comments on the bottom two things. I mean, we know there's a lateral injury. As a surgeon, I have dealt with it, but I'm not going to rely just on my suturing and my T-tube. I want you to help me in the form of a stent placement. I can put a stent from above. You can put it from below. Any difference between the two? Which do you think is ideal for this kind of a situation?
Well, I feel if you're going to not do a T-tube drainage, then if you have an intraoperative ERCP services expertise available, that would be the most ideal thing. Post-operative ERCPs, this is what generally I am called for, where patient had a surgery and unfortunately on table there was no detection of a small leak, and it could be a bile duct lateral wall injury, which we have, post-operative within the first 72 hours stented. So yes, I think endoscopic stenting would definitely salvage the situation of a small lateral leak.
Sure.
There's no doubt about it.
Great. Thank you so much. Well, for want of time, I'll just quickly go through the other slides and we will go to the last scenario. If I can get Dr. Bharat in for this. Chronic calculus cholecystitis, lap chole done, callus dissected, lap chole done. But the cystic duct, according to the surgeon who talks to you later after the operation, was a wide duct, and he had to apply 2 clips along the breadth of it. But he thinks everything went fine. Patient goes home, no drain, comes back to you a week later, severe abdominal pain, not eating properly last 1 week, a lot of pain, diffusely tender. You do LFT, those are the LFTs. What would you do?
This looks like definitely a classical injury cutoff of the CBD.
Yeah. So
with which is clipped again, so that there won't be any bile in the peritoneum. But then definitely the patient would have severe jaundice and
yeah. So we're looking at a major bile duct injury.
Major bile duct injury.
Fair
I would like
enough.
to do an MRCP first.
Yeah. Well, that was going to be my next question. So Dr. Senthil, see, it's 1 week post lap chole, right? Is there any role for re-laparoscopy here?
If there is no signs of peritonitis.
Well, this lady has peritonitis. She's diffusely tender. She's got peritonitis. I mean, she's not able to walk properly. Somebody has just lifted her to your OP.
Then imaging. If
what
it
imaging?
shows,
MRCP or CT?
okay.
And why? Sorry, I'm rushing through for want of time.
If it's peritonitis, I would prefer to go for a CCT.
Okay. So, Dr. Manish, would you go for? Is there any particular reason? I mean, I agree, Senthil, CT, but is there any particular reason why you would want a CT?
The one thing I would want is a MRCP.
You want an MRCP, not a CT?
Yeah, MRCP. Why? To see what has happened.
The biliary.
Complete transaction,
Okay.
look at the biliary tree.
Right.
That's the first thing I would want to
well,
see.
Just a couple of points I want to emphasize here. Both are right. Dr. Senthil is right. Dr. Manish is also right. CT has the advantage that it will give you information about vascular injuries, which can happen in about 60 to 70% of major bile duct injury. We already agreed this is a major bile duct injury. MRCP has the advantage of giving you an excellent biliary, dilatation and all that, as Dr. Manish Baijal said. So both are equally okay. Let's say that's the MRCP. Quickly, Dr. Rathod, if you can please comment on that.
Yeah, looks like a serious bile duct injury.
Yeah.
Well, there are debates on, there are a few very anecdotal cases, of course, we have done where there is a total transaction, where I'm not talking of anecdotes, but it has been a traditional teaching in surgical schools that once you have a transaction like this, the best way forward is definitive surgical intervention.
Absolutely. So,
but there are now some very interesting techniques which are developed, which I thought I must share with our colleagues. There, where what we do is we do something called a rendezvous procedure with an interventional radiologist with flexible needles, which we insert in the bile duct, and at the direct cholangiographic position, we puncture the needle into the dilated segment of the biliary tract, and we create a sort of a track, and we place a plastic stent initially.
What's the timing of your procedure, if I may ask? How many days post lap chole?
We can do it after maybe a week or 10 days.
So basically, you can do that whenever the patient presents. Is that what you're saying?
Yes, you
Okay.
can.
Because I'm going to come to that. When it comes to surgery, there's a specific window period. You're not
Yes.
supposed to touch the surgeon.
And
Not
because
supposed to touch the
the
patient.
reason is of the least invasive nature of intervention.
Fair enough.
And that is the point.
Well,
Now-
I wish I had more time to let you explain the roundover procedure,
Yes,
but we have to
but-
move on. I'm really sorry. So I'm going to ask you this question, Dr. Bharat. What's the ideal timing of surgery for a major bile duct injury and why?
The patient should be free of all the peritonitis, number one. If there is a fistula, it should have been well drained fistula. The tract should be well formed.
Yes.
And then I would wait at least 3 to 6 months, depending on how well the duct is dilated.
You would wait even up to 6 months?
3 to 6 months, depending on how well the
Okay.
duct is dilated.
All right.
If the
Dr.
fistula is
Senthil,
well established, and
Dr.
it's draining
Senthil, major bile duct injury, say a patient comes to you on day 10, and we entirely agree with Dr. Bharat has said, drainage of cholangitic sepsis, drainage of peritoneal sepsis is the key, that's a priority, and that has been achieved. PTBD in, ERCP stent in, abdominal drain in, nicely exteriorized, controlled biliary fistula. Patient is fine, walking, but he's on day 14. When will you ask that patient to come back and see you?
Definitely the repair will be 3 months, minimum 3 months. More the delay, the better would be the result.
So what does the literature say about the waiting period?
Waiting period, see, it's about minimum 12 weeks. It's about, see, within 72 hours is the early repair.
Correct.
3 days to 20 days is the intermediate phase. Please don't do anything in this intermediary phase.
Yes.
If it is within 3 days, if you are capable, do it. But personally, I don't believe in that one.
Okay.
Except complete cutoff without bile spillage. You just clip it and divide. You can do the surgery anytime you want. That's a completely different scenario. But if it is exposed with the biliary fistula and pancreatitis, biliary peritonitis, more the delay. I totally agree with Bharat. Literature says 12 weeks. Yes, 12 weeks is about 3 months. Minimum 12 months, 12 weeks. But here the tendency is, I don't mind waiting for 4 months or 5 months till the bile duct nicely dilates, inflammation settles, so that you have a nice, good porta hepatis for us to go and operate. The first attempt is the best attempt.
First attempt is the best attempt. I think that's a very, very important statement to make. So the key message here is that you either operate on the patient in the first 72 hours. You meaning either you as the surgical gastroenterologist with an interest in biliary surgery, or your colleague to whom you have sent the patient after that bile duct injury, first 72 hours. If that hasn't happened due to clinical reasons or logistic reasons, your aim has to be relief of sepsis, relief of two kinds of sepsis. One is the peritoneal sepsis, the other is the cholangitic sepsis. Cholangitic sepsis, PTBD, ERCP, stenting, peritoneal sepsis, drainages, how many ever you want, 2, 3, and then the patient should get better. And then you think about an operation no less than 6 weeks. But yes, 2 months, 3 months, perfect.
Dr. Jameel, just one point if you don't mind.
Yeah.
Very quick. Now, if I see a patient post-operative with a suspected transaction or a clipping of the bile duct,
Yes.
and on fluoroscopy, what we check, if there are multiple clips seen in that area, what we have also observed is that sometimes the clip is onto the bile duct and it so-called appearance is on MRCP is a transaction. It is not a transaction. It is just clip across the bile duct. In such situation, what we have done is we have absolutely gone into the bile duct and managed to dislodge the clip and we have put a stent. So my request to all the colleagues is that you be very careful when you say there's a complete transaction or there's just a clipping across the bile duct.
I think that's a very, very interesting thing to but then whatever.
I would add one point here. The logic says that when you have clipped, you have to also cut also. So
No, Dr. Rathod is talking about he's talking about a specific scenario. A specific scenario.
Clip across the bile duct.
A specific scenario where there's blockage, but no active bile leak, and that's the one where you will be able to dislodge. Correct. But not everybody can dislodge the way you do, I suppose. Okay, fine. See, look, this is a very interesting topic, very common topic. There are conferences just themed on bile duct injuries. So we can't do justice to this topic in half an hour or 40 minutes. So we'll have to wind up the discussion here. Just a few take-home messages. please understand that this is a preventable complication. It is it's something that we inflict upon our patients, and we shouldn't be doing it in an ideal world. All these adjuncts, IOC, laparoscopic ultrasound, intraoperative cholangiogram remember, they are only adjuncts. They are not replacement for safe surgical principles of laparoscopic cholecystectomy. Learning curve, mentoring, extremely important. And as we have very clearly got the message across, the best repair is done by the experienced surgeon immediately. And last but not the least, when in trouble, abandon the operation, drain, and refer. I thank all of you for your patient listening, and I thank so much my panelists, Dr. Vipulroy Rathod, Dr. Bharat Kumar, Dr. Arupabha, Dr. Manish Baijal, and Dr. Senthilnathan. Thank you very much.